Okay, so in this video, we're going to talk about health policy in a bigger picture. So in the previous chapters, we have talked about the markets for healthcare and health insurance, and we have pointed out a lot of problems that can emerge if we don't handle them. Okay, so for example, in the markets for healthcare services, there is not enough competition. So there is oligopoly pricing or monopoly rents for doctors and specialists. And sometimes it's too much competition that leads to medical arms races. And then in health insurance market, the most typical problem that we are familiar with is adverse selection and moral hazard. If adverse selection happens, healthy people are going to drop out, and it's going to lead to higher premium and underinsurance because some people couldn't afford it. For moral hazard, people will choose to use whatever that is available, and this creates too much burden for the system, and it could lead to technology overuse as well. So lots of problems. We need health policies to try to deal with these problems. So now we're going to introduce Arrow's impossibility theorem that is related to why it is so difficult to design a health policy that can satisfy everything. So the task of designing a national health system is at its heart of an optimization problem. It's not this similar to the task of an individual in the Grossman model. In the Grossman model, a person has to maximize its utility. And for a country, it has a task to maximize its welfare for all. So societies must decide how much time and money they want to spend on improving their health and how much time and money they want to spend on other things like military and education. They must chart a strategy for achieving the level of health they want, both cheaply and efficiently. But this analogy between an individual and a society is not quite right, because an individual can have a consistent and transitive preference, while a society does not necessarily have. So without a transitive preferences, welfare economics falls apart. And to have transitive preferences, a person, a group, or a society that prefers choice X to Y and Y to Z must prefer X to Z. Okay, so here is the definition of transitive preferences, and we're going to show you an example that why economists can prove that this is impossible. So suppose we have three types of voters in the society: students, workers, and retirees. And if we just focus on two parties, Fed Dems and social libs, we can see that for students, they prefer Fed Dems over social libs. And for workers, they also prefer Fed Dems over social libs. Okay. But if we look at the retirees, they prefer the opposite. Okay, they prefer social libs more than Fed Dems. Okay, so then you have a society that people have some preferences, but they are not consistent. Okay, we call that transitive. We call that this society does not have a transitive preferences. So the implication that Arrow's theorem have is that it doesn't make sense to speak of an optimal health policy for a country because people prefer different things. They don't have a preference that can be optimized in the traditional sense. For a person, you can have that, but for a society that consists of different persons, you can prove that it is impossible. Well, but even though this is not possible, nevertheless, political decisions do get made, and various national health policies have emerged. And we will talk about these policies one by one to see what are the trade-offs that different policies are making. So the health policy trilemma, okay, not a dilemma, but a trilemma, is that nations have three broad goals in mind that they want to achieve, but they cannot have all three of them. That is health, wealth, and equity. Any attempt by a nation to move closer to one of these three goals necessarily involves a trade-off that move away from one or two of the other goals. There will always be trade-offs, so there will never be a perfect healthcare system where all three goals are maximized. Furthermore, people disagree about how important each of these three is. In some country, wealth is more important than equity. Okay, so this is speaking of more general, like income inequality views that different countries have. And when you introduce health as well, then people will have different preferences over three of them. Every health policy choice involves a trade-off between one, two, or three of these. And the policy options that follow are thus presented as answers to three broad questions that any national healthcare system must answer. That is, how should insurance market work? How are you going to control moral hazard in public insurance? How should healthcare provider markets be regulated? Okay, so let's start with health insurance markets. We have several options that a country can have. A country can have one of them or several of them combined. So these are completely private insurance markets, universal public insurance, compulsory insurance. I'm gonna explain what's the difference between universal and compulsory, and then employer-sponsored insurance and means-tested health insurance. The first option is completely private insurance markets. And this is the worst for adverse selection, because in the private market, the healthy people will drop out because they don't want to pay for the sicker enrollees in the plan. And now once the healthy people dropped out, the premium will increase because the rest of the people are sicker. And as the premium increase, some people who are not rich enough will also drop out because they couldn't afford it. And this vicious circle keeps continuing, and the relatively healthier people will keep dropping out, the relatively poorer people will keep dropping out. And at the end, no one will be insured. Okay, so under these circumstances, economics can prove that a completely private market can unravel completely, leading to uninsurance for everyone. The happy thing about this is that taxpayers may be happy with the low tax bills, but many citizens will not be able to buy full insurance. Okay, so the second option is a universal public insurance. In this situation, the government provides insurance for all citizens. Basically, no one has to buy insurance. The government buys it for you from the tax money that you pay. This policy option is appealing because it takes adverse selection completely away. No, there is no healthy people or poor people dropping out because everyone has to buy it and the government is in charge of buying it for you. It also furthers the goal of equity because the poor people would not needs to pay that much tax. So in essence, it's the richer people whose tax money is subsidizing for the poorer people's health insurance. The problem of this is that once everyone is insured, everyone would think, oh, now I can go to hospital whenever I want. And I might get all the unnecessary healthcare services that could be a huge budget burden for the government. So the government must take a lot of measures to control moral hazard. Otherwise, it will explode its budget if moral hazard is left unchecked. Another problem of this is a higher tax. This is a major concern for some countries that sees tax as a major threat to economic efficiency. Tax distorts behavior by discouraging labor and commerce, so the entire economy may be less efficient as a result. But some argue that the universal public insurance is more efficient than private because of low overhead costs. So then higher taxes are one of the costs of public insurance. Note, this is a single payer healthcare because only one entity is paying for all the care, which is the government. The option 3 is called compulsory insurance. It's different from public because even though everyone has to buy, which is required by the government, that everyone has to buy insurance, this insurance is not provided by the government. Okay, so this is a mandate that also takes adverse selection away, but they allow private insurance to take care of the rest of the system. Okay, so a mandate sounds good that the government doesn't need to manage all the health insurance thing, but a mandate is still costly because you have to spend efforts to make sure everyone does buy insurance from a private company. Some citizens might not be able to afford it because you are not subsidizing through a public insurance from the richer people's tax money. So the mandates, in order for mandates to work, the government have to sometimes subsidize the poor people using tax money. So a mandate is still public finance. It still uses tax money, even though it sounds like it's just a mandate. It must also be carefully defined and it can be completely ineffective. So people might end up buying very cheap health insurance from private companies that offers a very minimal level of coverage. And they will still be scared to get very sick because the expensive procedures are not covered. Examples has Japan, Germany, and Switzerland. Option 4 is employer-sponsored insurance. Under such a system, employers are required or encouraged to offer a private insurance contract to all of their employees. So this is familiar for United States citizens that you have to get employed to get insurance. This is nice in a way that it encouraged people to get jobs instead of just waiting at home and get welfare. The problem of that is that some people will be afraid to be unemployed, and this can lock them up in their jobs that are not wanted by them, and that creates inefficiency. Another nice thing is that in a company, there will always be healthier employees and sicker employees. And so you make sure that when a company buys a kind of like insurance package for the whole company, there's always a pool of sicker and healthier employees. And this can help solve the adverse selection problem. That is, if you're healthier in this company, you want to drop out, but you don't necessarily get to drop out because the company buys health insurance for all of you. Option number 5 is called means-tested insurance. It simply means that government provides subsidized healthcare for the poor. Example is Medicaid in the US. So Medicaid covers people in the US that's under certain level of poverty line, and also women who are giving birth and doesn't have insurance. Okay, so it attempts to improve equity by providing healthcare to those who otherwise could not afford it. And this is very, very useful because if a woman that is giving birth and doesn't have health insurance, this could have very bad damage to the health of a newborn. And a newborn's health is the most critical health for a lot of people in their entire life. The cost of expanding this is, again, tax money. Once tax money is involved, it's related to the economic efficiency overall. Another thing is once healthcare is provided in a subsidized way, you also need to control moral hazard. Okay, so then the next question is how do we control moral hazard? What are some tools that we can use? In a private market, private insurers compete to offer them an optimal mix of insurance coverage and moral hazard. But when the government enters the insurance market, it's the lawmakers and policymakers that has to make these tough decisions. And it's tougher for them to make decisions than the people in the private insurance companies, because moral hazard control is always controversial and politically treacherous. That is, where do you draw the line about what could be covered and what should not? Policymakers do not have a neatly labeled figure to help them make these decisions. So they must make some educated guesses about how much moral hazard to eliminate. So here are some tools that they can use. The first one is called health technology assessment. Some people call them cost-effective analysis. The second one is called cost sharing. The third one is similar. It's called gatekeeping and queuing. And the last one, I think is the most popular one, that is called prospective payments. So first, cost-effective analysis. Basically, it entails gathering information about treatment options and determining which options produce the most additional health for the least cost. So for example, if someone gets cancer and now there is 2 treatments available, one treatment is cheaper and it saves you 5 years of life. Another one is tremendously more expensive and it saves you 6 years of life. So even though there is an extra year for life expectancy, but if comparing this to other diseases and other treatments, that this extra amount of money is too huge for an extra year of life comparing to other type of treatments, then this cost-effective analysis might decide that, okay, we're going to cover the one that is cheaper and save 5 years of life, while if you want to pay for the extremely expensive payments, you have to pay it for yourself. So this will limit moral hazard by reducing spending on inefficient and costly treatment. But again, thinking about life as money is very controversial for most people. So the trade-off is that even though it makes the system more efficient, it could ravel a lot of controversials. So for example, if you deny coverage for some treatment, politically, it would face a lot of backlash. Some governments have embraced cost-effective analysis, like UK, Canada, and Australia, while in the US, this is forbidden, okay? US Medicare is forbidden by law from using CEA in its coverage decisions. Medicare covers any medically effective treatment, no matter how expensive it is. Okay, so the second option is cost sharing. Basically, it asks the patient to pay a little bit more while it's covered for some other cost. So if you have been to some of the US healthcare systems, you hear these words like deductible, coinsurance, copayments. You probably find them very difficult to understand, but basically all of them is some type of out-of-pocket cost that an insurance patients have to pay when they receive healthcare. So imagine if you have to go to see a doctor. If you don't need to pay anything, you probably would like to see as much as you want. But if every time you are required to pay a copayment, let's say $10 or $20, which is not that expensive that poor people cannot afford, but it gives people an incentive that they have to be efficient in decisions about how much hospital visits that they want. So this controls moral hazard in a way that is sometimes more politically palatable than CEA, but it also makes healthcare less affordable for some patients, and it could undermine equity. An example of US Medicare is that in 2012, a Medicare patient if a Medicare patient wants to be admitted to a hospital, he or she has to pay the first $1,156, and then the rest of it will be paid by Medicare until the 60 days. And after 60 days, if he or she is still living in the hospital, he would have to pay $289 per day after that. So he has to be efficient in the number of days that he or she wants to be in the hospital. So this forces enrollees to either economize or purchase supplemental private insurance for this situation. Option 3 is gatekeeping and queuing. Basically, it makes people wait or keeps people away from some unnecessary visits. So for example, in gatekeeping, people see doctors in a tiered system in a specific order. So they might see a generalist first. And then if the generalists think that this person really needs to see a specialist, then he or she gets to see a specialist. So this will keep the cost down by eliminating frivolous appointments on specialists. Public insurance system also control costs by limiting the total amount of specialists available. So when demand is larger than supply, people have to wait in line. And usually a line is an inefficiency in economics. But in the case of healthcare, a line can help discourage people who doesn't need it so much. So if someone who needs healthcare, he or she will stand in the line anyway, because it's very necessary to get that help. While for some people, it's not that necessary. So then they will be discouraged from that line. And so that line serves a role of controlling moral hazard, even though the line itself is inefficient. And having a line can also provoke political backlash, which is always a problem when we're designing a healthcare system that involves political decisions. Okay, the last one is called prospective payments. This is the opposite of fee-for-service payment or retrospective payments. For retrospective payments of fee-for-services, the insurance company have to pay the hospital for every procedure separately. In this situation, doctors have no reason to deny patients services because the costs are too high. This system is nice that it fosters trust between patients and doctors, because doctors will always give you the procedure that you need, because every procedure will be reimbursed by the insurance. The problem is that it will create incentive for physician-induced demand. So prospective payment tries to solve this by saying that we're not going to pay for you for every procedure. We are just going to pay for you for the entire episode. So for example, if a person has a heart attack and comes to a hospital, then I'm going to pay you a specific amount no matter what you did to this patient. Okay, this fixed amount for heart attack patients, and any heart attack patient that come into the hospital is gonna make a certain amount of money for the hospital. And so the hospital would think, okay, then now I don't want to order unlimited amount of unnecessary tests or procedures. I want to be as efficient as possible to treat this patient, because no matter what I do, I'm getting the same amount of money. This is an efficient way because in 1980s, governments around the world have embraced these payment schemes as an effective way to reduce moral hazard, because it always creates an incentive for the hospitals or the physician to be as efficient as possible. But the problem is that doctor-patient relationship can be bad, because the patient would think the doctors want to make money and order the cheapest or the shittiest service or procedures for me. In one study that conducted in US after this payment program has implemented, patients' mortality increased significantly at a subset of hospitals after the transition. Okay, so how should healthcare provision be regulated? Recall the maladies of private healthcare markets. There is sometimes not enough competition that leads to monopoly or oligopoly. Sometimes it's too much competition that leads to medical arms races. And physician-induced demand is part of the problem of moral hazard, but also part of the problem of healthcare provision. So what set of policies can combat these maladies without creating new inefficiencies that are even worse? Okay, so the available options are public provision, private hospital markets, and the government set prices. The first one is called public provision. So under this approach, hospitals are government run and financed by taxes. Physicians are employed by the government. Okay, once things are public, competition are taken away, but prices can be set by the government. So the nice thing about this is that government can set things at a price that most people can afford, and this is going to improve equity and reduce costs. The problem is that we have a lot of nice thing about competition, that competition can make products higher quality, competition can drive prices lower, and once we take competitions away, these nice things from competition will be lost as well. Empirically, this is a problem empirically. So what kind of system actually drive costs down? So they did, there is this comparison between countries that they calculated how much healthcare cost in it as a share of GDP. So in UK and Sweden, it's 7 to 8%. In France and Germany, it's 11%. And in US, which is private predominates, it's 15 plus. I believe it's 20% now. So then empirically, it seems like private markets are less efficient, or the private markets have higher costs. The problem is that the common charge against government-run hospital is that they offer lower quality care. You may argue that the healthcare quality in US is better than the other countries. That's why it's more expensive. So it's in numbers, it seems like US is less efficient because it takes a private predominance. But the problem is there are so many other factors playing in that you cannot completely argue that if we enforce a public predominant provision system in US, it will necessarily drive the cost down. Or you cannot establish a causal relationship between private and public on share of GDPs that a healthcare system that would cost. Okay, so the second option is private provision, that you have private hospitals and private physicians. Nice thing is that there will be competition. Different hospitals and different physicians can compete with each other on driving the prices down or improving their quality. And the problem is that when there is not enough competition, it could lead to market power and monopoly or oligopoly price. If there is too much competition, again, it will lead to medical arm races, which is going to increase healthcare costs. Some other concern is that is from an equity perspective, that some populations like the poor and uninsured will lack access to health. One solution is to subsidize those, is to give that tax breaks to nonprofit hospitals, which historically have attended to the poor and the vulnerable. Most developed countries also require hospitals to provide ER care to incoming patients, regardless of their citizenship status or their ability to pay. Such last resort laws promote equity by ensuring a minimum level of care for everyone, but they also impose costs and deter hospitals from building emergency room and trauma centers. The last option is government set prices. Government can set price to prevent private providers from charging something extremely high. In theory, such price control could contain hospital costs, but government set prices could also induce some preserve incentive. For example, pharma companies would be discouraged from innovating. So unless prices are set properly, treatment price below marginal cost may not even be offered, while the most profitable services may be overprescribed. Okay, so here is kind of like a conclusion for benefits and costs for various national health policies. We can have different health insurance markets, and there are different examples in different countries. The benefits of some health insurance markets is that it can take away adverse selection. The cost is that once you take away adverse selection, you have to control moral hazard and you have to charge higher tax. In order to control moral hazard, there are different ways. So a lot of them efficiently controls moral hazard, but it's controversial. Some of them reduces equity, while some of them will restrict access to healthcare. Lastly, how is healthcare provision regulated? Some of them are more regulated, which will promote equity. Some of them are less regulated, and it will reduce equity. And at the end, it's an empirical question about which one is more efficient. Okay. So every country has its own set of policies. they can be classified into three of these broad groups. The first one is called a Beveridge model. In the Beveridge model, there's only one payer, which is the government. There's public provision of healthcare. There's very little cost sharing. It has high emphasis on equity, and it has to control moral hazard. The second model is called Bismarck model. It's a mandate that everyone has to get private insurance. Hospitals and doctors are private. There's a strict price control set by the government. It balances equity and liberty at the same time. And the last one is American model. It's unique to US because US is the one that emphasizes private market in the central role. There is no mandate for universal insurance. There is no price control. There is some public insurance for some groups, like the poor, the elderly, or pregnant women. And it emphasizes liberty. If we have to use our previous analysis framework, which is a health production function, to see which one is efficient, which one is not, then we can draw this line again that if we spend more healthcare per capita, then you're gonna expect better health. For example, life expectancy. So most countries are on this line or near this line. Some countries are way above this line, like Japan, which means that Japan spent the same amount of money like Spain, Italy, and Finland, but achieve much better health in terms of life expectancy. Some countries are way below this line, like US, that it spends so expensive on healthcare, but it does not achieve the expected life expectancy that it should be achieved on this line. It's way below this line, okay? Or somewhere like Denmark that spends as much money as Australia, Germany, and France, but achieve much lower health. The problem of cross-country comparison is that what if different countries have different inherent level of health? For example, some people would say people in Japan just naturally eat healthier and they have better lifestyles. So they inherently have higher health than the other countries that spend the same amount of money on healthcare with Japan. What if people in different countries value health differently? What if countries differ in how much health inequality exists? So without taking all of these things into account, cross-country comparisons is not necessarily useful. It is not clear whether all countries are on the same health production frontier or health production function, or whether US is on a completely different HPF than the other European countries. So for example, in the first figure on the left-hand side, if all of these three countries share the same HPF, UK, Switzerland are on the line, which means that they are efficient, while US is below the line, which means that US is not operating efficiently. But in the second figure, suppose US is in a different frontier line. Then it simply says that everyone is efficient. It's just the production function is different. Okay, so then lastly, there is also preference for health. So even if a country is productively efficient on health, what about their money? What about their preferences over other things? So for example, it is possible that the marginal dollar spent on education or parks produce more utility than the marginal dollar spent on healthcare. Then from a public finance perspective, this country is not maximizing its welfare because it spends too much money on healthcare than education and health. They should allocate the marginal dollar from health to education until the marginal utility across these different groups is equal to each other. So then in such cases, shifting money will make it less efficient, but it will increase the overall welfare. Okay, conclude. When government policy can, while government policy can address some of the problems created by information asymmetries, such as adverse selection, moral hazard, countries that have adopted policies that solve them face significant challenge in controlling moral hazard. By contrast, US, a large segment of the population is uninsured, and this is always a problem and a controversial debate between different parties.